All right, Mina. So I'm going to give you a rundown of kind of how assessments have gone for our COVID patients, and I think an important thing to understand is, and particularly in the situation we're here in New York, um, is that things are markedly different than what they are in what would be like a perfect um, nursing situation. Nothing about this situation is even remotely close to normal. You've watched some of my other videos, I think, so you kind of get a feel for what it's like here. I have primarily spent my time here in the OR ICU, so some of these patients are the sickest of the sick. They are almost to a T. They are either intubated or with a new trach placed. They are on either sedated if they're intubated or coming off sedation if they are fortunate enough to have a trach. Um, the problem is we're working, and this is kind of part of problematic of the whole situation. We are working with residents and doctors who, so the doctors are generally okay. Most of the attendings have a little bit of experience, but some of these attendings pull from areas where they have not dealt with acutely ill patients. And then we have a lot of residents who um, have not done the same either. They're just fresh out of school. They've been thrust into this situation, which is just remarkably complex. And so, as I go through kind of how we assess, then I'll explain some of the challenges behind an assessment. So, in terms of um, like an advanced assessment, like we've done for this class, I can tell you straight up front that a lot of this stuff is not getting done in this situation. I mentioned in my first video that there is a very real focus on minimizing time spent in these COVID rooms. So, the rooms that I take care of, I am the lead nurse over one OR room that has 3 COVID patients. So, this is 3 intubated, 3 sedated. They are typically on pressors. Most of them are on Levophed. Some are on Vaso. Levophed seems to be the pressor of choice. A good portion of them are on Precedex. A good chunk of them are on Propofol. And then you've got some sort of analgesic opioid, so fentanyl or Dilaudid. A little bit interesting, just from a pharmacological standpoint, that we're not seeing a lot of morphine drips used, which I found interesting because, and you know this better than I do, morphine kind of ideally suited in an ICU setting because good analgesic and good sedative properties, but they're not using it. Mostly it's Dilaudid, mostly it's fentanyl, and then the Propofol and the Precedex, and almost everybody's on some combination of those. So when I get there at night right when I walk in, I get all my meds squared away, I talk to the doctor, make sure if there's stuff that needs to be rescheduled, I can get it rescheduled so that I set up everything in 4-hour blocks. And then that way I'm allowed to go in the room. Allow myself to go in the room at 8 o'clock, do full assessments on all of my patients, typically bathe and clean one of my patients, administer any meds that I need to, stuff like that, get them all repositioned. Then I go back in again at midnight. I mean, you're kind of in and out of the room in between those hours too, if someone's blood pressure's softening or if maybe someone's getting a little hypertensive. But then I go back in at midnight, we'll bathe another patient, reposition everybody again, do another full assessment, then go back in at 4 o'clock, same thing, bathe the last patient, get everyone repositioned again, meds, whatever. So it's a complex situation, it's not ideal. But when I go in for my assessment, it really is, I mean, the way we do the assessment is the same as kind of a general assessment anyways, but there's just some stuff we're not going to assess. So I go in, do a general survey of each of my patients. That one's pretty quick. So I'm just getting a look. What do they look like? And I can tell you most of these patients they're in pretty bad shape. So general appearance, we look at, there's no clothing, obviously, they're all in gowns. Really, skin is the big one. Um, there's not much to look at in terms of mentation or cognitive ability because they are all sedated. Um, some of them do open their eyes occasionally. Some kind of respond to pain, but in terms of following commands, in terms of movement, there's just not a lot. And one thing I've been struck by through all of this is how weak all of these patients are. So I've had one patient who we were weaning off sedation. We had shut off Precedex, and just all of these patients in general, the generalized weakness across their entire body it's incredible. They can't lift their arms, they can't lift their legs. The one patient that I weaned off of his sedation, he was able to follow commands and squeeze my fingers, but that was it. That was the extent of his movement. Can't even turn his head to look. And that seems to be kind of across the board. So, how much of this is sedation? Are we going to find out that some of these patients have had strokes? We're not noticing any pupillary changes or anything like that, but one of the things they found with COVID-19 is a lot of coagulation issues. So a lot of these patients are heparinized. Did they have microemboli before that? Are they now hemorrhagic? I mean, we watch what neuro things we can watch, which really comes down to the pupils. We can assess pupils. Difficult. I mean, yeah, there's just so much that is difficult about it. So anyways, go in, general survey, look everybody over. Then I move on one patient at a time and I follow the same process. I always listen to the lungs first. This is I guess I could go head to toe, but this is just how I do it even when I'm at work normally. So I'll get my stethoscope. I'll listen to all my lung fields. Oddly enough, most of the lungs sound clear on most of these people. A little bit diminished sometimes in the bases, but for the most part, not getting a lot of secretions out of them. Lungs actually sound pretty good. Then I listen to the heart because I'm right there with my stethoscope. Move through the process of the heart. A lot of these patients have underlying hypertension, but typically not a lot of heart issues. And I've not yet had any patients where I could audibly discern anything. There were no murmurs or anything. Heart sounds typically sound pretty good. And then we move on to the bowels. Bowels don't get a lot of bowel sounds. Most of these patients that are on the opioids and stuff, and they've been on them for 3 weeks, there's just not a lot going on down there. And then I will move to a head to toe. So I'll check my pupils first, make sure they're equal and reactive to light, sluggish versus brisk, kind of the same thing that I do typically at work. And then I really pay special attention to skin. And if you're going to ask me what's the most important thing for us to assess right now, it's skin. The amount of bed sores that I have seen here, the amount of edema is, it's unfortunate. And part of this problem has been there were so many patients all at once, not enough nurses, not enough skilled ICU nurses, people really just hanging on for dear life. And there had to be decisions made between what was important and what wasn't. And keeping these people alive was important, and assessing their skin was not. I know, like, we could debate that. I get that. But that was sorry, just adjusting myself in the chair. That was one of the things that me and some of the people that I came with have talked about, really, is how do we improve the standard of nursing care they're getting? Because we're only here for a couple weeks, so we've got a lot of energy that we can devote to it. Can we get these people cleaned up? So I do a head to toe. Pay special attention to the back of the head. Some of these people have been sitting on pillows. Their heads aren't getting moved around. I've seen really bad pressure sore on one person's back of their skull. Never seen that before. And remember, these people are on pressors as well. And so you've got poor circulation already. And then they're just sitting in one spot. Some nurses aren't rotating them. Like, I'm not saying this is an indictment against other nurses. It's not at all about that. They're doing the best they can in the situation they're in. But this is just kind of the reality of it. So then I'll move down all the way through their body. I check their arms. I check their hands. any IV sites that they've got. All of these people have art lines in place. They all have either a PICC line or an IJ, and then they all have multiple PIVs. So I assess all of those sites, make sure there's no bleeding, no tearing of the skin, and move down the body. And then once I get just what I can see, so if they're laying on their back, I get the front of their body, check everything out, make sure there's no new pressure ulcers, there's no new sores, nothing that needs to be band-aided or covered or charted. And then I go back up and then I start like a full CV assessment. So I've already listened to the hearts, but I check skin, cap refill. Like I can generally see skin already when I'm in there. What does their color look like? Check for their pulses in their peripheral, so typically on their feet. And then we'll do like a radial pulse, just make sure that we're getting good perfusion and good pulses to all four extremities. Make sure we haven't got an occlusion somewhere. Everyone's wearing sequential compression devices already because nobody's getting up and moving. I mean, they can't. Nobody can move at all. So check out all those. I've not ever really palpated like a carotid pulse or anything. It's one of the differences, I think, and partly what I've learned with taking this class is being in an acute ICU setting is always just a little bit different than other types of nursing. We have so many diagnostic tools at hand. Typically, CTs have been done, MRIs have been done. If we were in the cardiac, an echo's been done. And so all of this stuff, like we have all of this stuff that helps us to keep track of what's going on. Now, in a cardiac ICU setting for me, like I can always obviously assess for changes in what the baseline is, what we've already established. And in this situation, we can do the same. But typically, like if you've got a good art line pressure, if you don't have a narrowing or a widening pulse pressure, no pupillary changes, then we kind of, the people are typically, they're just kind of holding steady. And that's where all these people are at. They're just kind of holding pat. So I'll do that CV assessment. I've already got my respiratory out of the way. Check the head over real good. Unless we're weaning them off sedation, so I had the one patient, I can kind of do a little bit of a cognitive assessment. It's really difficult. What I found is that most of these doctors, they're unfamiliar with weaning sedation because they just don't have the experience. They do now, but they didn't. And still some of them are pretty young, and so they tend to wean the sedation fast, probably faster than they should. But even the ones that they do it slowly enough, there is the patients that I've had just the one guy that could follow commands for squeezing my fingers, but that was it. Like there's no attempt to answer questions. We would try with writing on a board or giving him a sheet of letters to point at to try to say something, and there's just no ability to really communicate. It's been really actually pretty difficult. You can see that they read. I held up a sign for that guy to, do you know where you're at? And he shook his head no, and so I explained to him where he was at. But they just don't retain it. So there's cognitive issues. Now, how much of this is hypoxic injury? How much of this is coming off sedation? We just don't know yet. I've not had any patients where we've had them off sedation long enough to know or to start to figure that out. I think it's going to take days for most of these, if not like a week or so for most of these people for that fog to start to clear. So we do what we can in terms of eye contact. The one patient I had that was awake, he did make eye contact with me, even though he couldn't really move his head, but he could track me around the room. But their level of consciousness is they wax in and out of consciousness. So sleeping versus wakefulness. There's not a lot of consistent wakeful time for any of the patients that I've had. Posture is not even an issue because they can't even hold themselves up. And so everything's just really, really different. So I try to do what sort of neuro exam I can on them. And then I've done my CV, I've done my respiratory, I've done my neuro. And then as we start to reposition the patient, then I go into kind of moving their arms. Most of these patients, you can see them wince, even the ones that are sedated. When you move their hips, they're all really sore, really stiff because they've been laying in bed for so long. So I try to do a little bit of range of motion with them, kind of work their joints out a little bit. And it's a good time because that allows me to see kind of what their natural range of motion is. I can lift their arm up. I can kind of rotate their shoulder a little bit, rotate them at the joints. I don't do any full tendon reflexes, at least I haven't on any of these guys. Mostly it's just to see what kind of movement, what kind of motion they have. And then we get ready to roll them. And so when we roll them, good time to clean. On the guys and on the girls, we do a visual, like a GI assessment, so we can check for, their perineal area, see if there's any breakdown. All of these patients have Foley catheters in. All of them have rectal tubes in. And so we get them rolled over, check their back. Almost every single, in fact, I'll say every single patient I've had has had a bed sore on their coccyx. I've had them anywhere from like a stage 1 or maybe a slightly just unstageable, progressing to or healing. I've had one healing to all the way up to like a stage 4 with a pretty bad eschar in it. Yeah, it runs the gamut. So then we do a full skin assessment on the back, paying special attention to the back of the head. Work our way down. We do a perineal assessment, make sure there's no breakdown around their anus or anything. Get them all cleaned up, roll them back, get them repositioned, and then I go back up and I do a full assessment around their face where their ET tube holder is. There's been a lot of skin breakdown on the cheeks here, a lot of skin breakdown on the lips, and that was not something I'd ever seen before, where these people have been intubated for so long, and then because they are on pressors and we've decreased their peripheral circulation, they're getting pressure ulcers on either the top or the bottom of the lip, wherever that ET tube is pushing on, or sometimes where the OG tube is pushing on. And so try to do real good oral care on them, try to get a good look into their mouth, see what their teeth look like, see if they're bleeding. We've had lots of patients bleed because of the coagulation issues, and then they're heparinized, and so we get a lot of spontaneous oral bleeding. People maybe have been a little too rough with oral care, so we get some bleeding. But just assess their cheeks, assess their lips, assess their gums, clean everything up real good, and then I pay special attention to the eyes. So one thing that they've found with COVID is that it can be passed through the eyes, and for some of the severe cases, which are the ones that we're seeing, there's a lot of pink eye and just actually like very, very red sclera and conjunctiva. So a lot of them, we're putting eye drops in all of them. I think Q6, most of them. So they get like Lacrolube. Trying to think what else. So pay special attention to the eyes, make sure they're looking good. And then typically there's no NGs, which surprises me. This is a difference between the adult population and the peds population. We NG all of our patients, all of my pediatric patients, but here everything's OG. And so again, just make sure the lips aren't breaking down, and if they are, that we put any kind of dressing we can to kind of help eliminate that pressure on there, and then make sure we get some good chapstick on there and start to get them cleaned up. There's no way to do like a swallow assessment. None of these patients are awake enough, and the ones that are trached, you would be able to, but even the ones that I've had that have been trached, we're still coming off sedation, and so we're just not. We're just not to that point yet. The patient that I had with a trach that had been off sedation the longest, she still was severely obtunded. And again, that was one of those cases where, what is this due to? Is this due to her being on sedation for so long, or, is there some sort of underlying hypoxic injury there? She wouldn't follow commands at all. She could not even squeeze my hands. She could track with her eyes, but that was it. It's just incredibly complicated, and it's really kind of sad to see. So, level of consciousness, really, like if I was going to raw score them, they'd be like, God, most of them -3 to -1. If I was going to do any of our cognitive, any of the cognitive tests like we've got, like people really would be a 0. Nobody can really do anything. I can't do any gait or anything like that. And even cranial nerve intact because they're not conscious enough to be able to answer questions or cognitively aware enough to answer questions. Like in terms of some of the cranial nerves, there's nothing we can do. We can do like a cough reflex, we could do a gag reflex, which we do typically get when we're doing oral cares. In fact, all my patients have had intact gag reflexes. Have had patients kind of mouth like they wanted to talk, but I mean, if they've been intubated, and so can't really discern what they're trying to say, and really, I don't think there's any coherent formation of speech or anything. Extremities, so I already talked about, we do range of motion, all of that kind of stuff. There's no real, so and then respiratory. Respiratory is a big one, especially once we've transitioned into the trach and we're starting to come down on vent settings. Then we really pay special attention to any accessory muscle use. If they've got symmetrical chest movement, sometimes that's due to positioning. If you get them one side down, and then you kind of get a little asymmetrical chest movement, but really for the most part, not seeing a lot of secretions from this. Oral secretions around the trach, but not a lot of lung secretions, which has been interesting. Hard to palpate for like tenderness. We can palpate for crepitus. I've not felt any on any of my patients. I try to do, as I'm working down their legs and as I'm feeling for skin, I try to palpate on their bones and around the joints, but I'm not feeling anything. And then, like I said, the only way to really assess for tenderness is when you move, and really the bulk of the tenderness has been in the hip joints, where they've just been sitting for so long and laying in bed. We make sure we do a good abdominal assessment since they have been on opioids, decreased peristalsis. All of these patients are getting like a full bowel regimen, and then you want to make sure if we have started feeds that their girth is not increasing and that they're not firm. And so, which is kind of difficult to do a little bit. Most of these patients have been obese, and it's been hard to really assess liver even with a scratch test because there's just so much adipose tissue on most of these patients. Everything really, like I said, it's just so difficult to do what we would normally do. And in the back of your mind for your own cognitive, function, there's always this sense of nervousness about being in the room. You're worried about your eye protection being on right. You're worried about your N95 mask being on right. And so you're trying to do the best job you can while trying to do it quickly, and get everything done so that you can get out of there. Right or wrong, that's the reality of it. So hard to do like span of liver or anything. I do a good abdominal assessment, all 4 quadrants, watch to see if I see any wincing on them while I palpate their abdomen, feel if it's firm, not firm, and then I get a good girth on them. And I'll do that twice. I'll get a girth twice a night on them. Difficult to palpate like aorta, stuff like that again, mostly because of just general weight issues with these patients. And so really to summarize, the big things we have focused on are neuro changes, and really that's really pupils for most of them is the only thing we can assess. Skin breakdown, skin breakdown, skin breakdown. Gosh, that's such a big deal, and such a huge problem. And then as we start to wean them down on sedation, hopefully trying to see them wake up. We've dealt with a lot of withdrawal. It's been one of the interesting things to watch. A specific case just last night. They'd had a patient on Precedex for 3 weeks and then shut it off. I mean, they didn't go from like 1 to nothing, but they'd weaned down slowly over a couple days and then turned it off. And But then the opioids, they did just shut off. And so these are patients that have been on them for 3 weeks, intubated for 3 weeks, and there wasn't a lot of consideration for withdrawal or anything. And then, sure enough, one of the patients got agitated and kind of moving around in bed a little bit. And this was a patient that was actually across from me. This wasn't one of my patients, but then having to restart back up the opioids again and then transition to enteral, which they should have done in the first place, then try to slowly wean it back down. And so there's been a lot of learning going on, trying to make the best of what is a bad situation. But unfortunately for the patients I've had, neuro assessments have been almost impossible. There's just not much to assess. That's how sick these patients are. So really the big things, respiratory status, which has been pretty good on most of them. They're on the vents, watching vent settings, seeing if pressure increases, stuff like that. Hemodynamic status, so how their pulses feel, quality of pulses, what their art line pressure is versus their cuff pressure, titrating pressors to keep those within range, trying to balance titrating pressors with peripheral circulation and all the skin issues that's going to entail, and gut perfusion. Yeah, those are really the big ones. And then making sure, actually, that's about it. Hygiene we're taking care of, obviously. I can tell you general survey on most of these people when I got here was generally pretty poor. Like it looks like battlefield medicine. There's no other way for me to explain it. And there just was not enough nurses and enough personnel to handle the job that needed to be done. And they've slowly caught up to that. God, it was a mess before that. So in terms of labs that we're drawing, labs are getting drawn every day, multiple times a day, depending on what it is. So if any event changes are made, ABGs are being drawn. Trying to see if there's any underlying metabolic disorders, liver function tests, BMPs 3 times a day. You want to make sure that there's no kidney failure. All of these patients are getting troponin levels drawn. There's been a lot of elevated troponin, and so this disease they're finding is as damaging to the heart as it is to the lungs. So we get troponin levels, coags on all the ones that are running heparin, and even the ones that aren't, because they want to see if there's any sort of indications for any coagulation disorders. So those get all done pretty not serially, but they just get done once a day. Other than the BMP, I think we do about 3 times a day, and then the ABG whenever vent changes are made, or whenever a resident gets a B in their bonnet, and they order an ABG. Trying to think what other labs I've drawn. And then we test them for SARS about every week. They've been getting a test. So some have been testing negative finally. It's been taking about 3 weeks to clear their system on average, which is much longer than I had expected it to be. Now, whether that's repopulating from the vent, could be. We don't know. But some aren't testing positive anymore, which is a good thing, and they're starting on their way to get home. Minor, the only thing I can tell you is this is unlike anything I've ever seen, ever. God. It's been a great experience. I'm happy that I'm out here, but one thing that I've noticed is that fear has kind of driven treatment in terms of nursing care. It's an understandable situation, but it's an unfortunate situation for these patients. It caused me to think back to all the advancements that we've made through nursing, through the advent of understanding that cleanliness was affecting infection and death and mortality. And even I've noticed that for some nurses who have been at this for 6 weeks and who are just exhausted, that even the basics of swabbing a central line with alcohol every time you disconnect or reconnect has kind of gone out the window. And so something we need to keep in mind and something we need to guard against, I think, as nurses. We've spent a lot of time discussing what changes, or what would we take back to Utah? What would we say to help prepare Utah if a situation like this ever happened there? And I think that's on a nursing level, those are the big things. We can't compromise nursing care. And so, whatever we have to do to have enough personnel to make that possible, then that's what we need to do. And I don't know what the answer is to that. That'll be for discussions later. But nursing care has really suffered. And again, it's not anybody's fault. I'm not criticizing, but I think we have to acknowledge the reality of it for what it is. Because if we don't, then we risk replicating that on our own, and that's not something that I want to see done. It's been difficult to see the state of some of the patients. The people that I'm here with, we've made a concerted effort to really improve the cleanliness and just the overall dignity for these patients, because they've been thrust into what is really, in some cases, been an untenable situation. So, anyways, that's kind of how it goes for us. It's complex, it's complicated, God, there's a lot of action going on, a lot of stuff happening all the time. Even though we try to cluster cares and try to be, only in the room, it never works out that way. I probably go through 50 gowns a night, maybe, going in and out, and taking care of the patient. And it's crazy, Mina. Crazy. Unlike anything I've ever seen. So I'm actually kind of okay with the B in the class. I debated about even doing this. I don't plan on going to MP school. That was in the cards for me at one time, but the thought of being done with school is really, and that may change in 5 or 10 years. The way my life works, it probably will change, but I was kind of okay with the B. Give me whatever grade you want on this. I told you it's unlike anything I've seen. It's different. So I want you to know, mine, I've enjoyed having you as a teacher. Glad to be done with school. This is my last semester. But I appreciate all the help you've given through the years, and grateful I got you this one last semester.